Okay, let's jump straight into this interactive explainer for high-stakes microsurgery and reconstruction. We're putting you directly in the shoes of the on-call reconstructive surgeon. Let's test that split-second clinical decision-making with our first case.
So, here's the scenario. A butcher cuts his left index finger and presents to a regional health center within 30 minutes. He needs to be transferred to your specialized plastic surgery unit, which is an hour away. The pressure is on. How exactly do you transport that amputated digit to ensure you don't literally lose the limb before it even arrives?
Right, so you absolutely want to go with option D, the ice protection protocol. To preserve that tissue for replantation, you've got to wrap the amputated digit in saline moistened gauze, seal it up tight in a dry watertight plastic bag, and then immerse that bag into a separate outer container filled with an ice water slurry. Now, what's incredibly crucial here is the absolute prohibition of direct ice contact. Why? Because it induces intracellular crystallization, meaning irreversible frostbite. And on the flip side, just tossing the part directly into a fluid like saline causes cellular maceration that completely wrecks the endothelial lining and makes your microvascular anastomosis basically impossible.
Moving right along into the OR. Once that thumb arrives safely packaged, what is the very first surgical action you must take on the bench? Are we starting with arterial repair, venous repair, nerve repair, debridement and bone shortening, or maybe skin closure?
The correct answer is D. You absolutely have to start with aggressive debridement and bone shortening. The foundational phase of any digital replantation requires you to meticulously clear out all non-viable margins, immediately followed by taking down that skeletal bone. This is mandatory because it decompresses the soft tissue architecture. It lets you cut back to healthy, uninjured vessel walls and execute your primary nerve and vessel repairs completely tension-free. After that, you follow the standard sequence: rigid fixation, tendons, vessels, and finally nerves. Okay, so the surgery was a success, and the replant is attached, but we have to monitor it constantly. How are we continuously checking that critical blood flow in the recovery room? Are we using Doppler ultrasound, plethysmography, pulse oximetry, or CT angiography?
It's C, continuous pulse oximetry. When you apply it directly to the digit tip, it's exceptionally sensitive for tracking both arterial inflow and venous outflow in real time. It's a lifesaver. If you see a sudden loss of the pulse rate waveform, you're likely looking at acute arterial thrombosis or severe vasospasm. Conversely, if you catch a steady drop in oxygen saturation falling below 90%, well, that's your early warning sign for venous outflow occlusion. Let's shift gears from digits to major calvarial trauma. We have a 30-year-old woman who suffers a catastrophic total scalp avulsion from heavy machinery. What's our absolute best management option here? A pedicle flap, scalp replantation using microsurgery, a rotational flap, free flap, or full-thickness skin grafting?
You're going to want option B. Microvascular reanastomosis is the absolute priority here. It's the gold standard for total avulsions, simply because the avulsed tissue segments typically preserve those clean, superficial temporal and occipital vessel trunks. Replanting this tissue is the only shot at preserving the patient's natural hair and avoiding a permanently disfiguring, dry calvarial defect. Standard skin grafts or local flaps, they just won't cut it for vast calvarial defects with exposed periosteum or bone.
But what if we aren't dealing with clean avulsed vessels? Imagine a patient just underwent tumor excision on the scalp and it left a massive 9-centimeter residual defect. What's the best treatment option in this scenario?
Here, we're looking at option B, free tissue transfer. It all comes down to the reconstructive ladder, which is based strictly on defect dimensions. Under 3 centimeters, primary closure. 3 to 6, local full-thickness flaps. 6 to 9 requires major pedicled local transposition flaps. But the moment you hit exactly 9 centimeters or larger, that defect is just too massive for local tissue. It strictly requires a microvascular free tissue transfer, like a latissimus dorsi or an anterior lateral thigh free flap. You have to do this to prevent extreme risks like chronic osteoradionecrosis and exposed bone desiccation. Zooming in on facial aesthetics now. How do we best repair a focal nasal defect that disrupts the structural contour, so the skin and fibrofatty tissue, but importantly leaves the deep skeletal framework entirely intact?
The answer here is D, a composite skin graft. When you harvest this from the earlobe or helical rim, it provides perfect simultaneous structural support and skin coverage. But here's the catch. Unlike a standard skin graft, a composite construct brings an intact subdermal vascular plexus with it. So, it absolutely requires a pristine, highly vascular wound bed to quickly connect to host vessels through rapid inosculation. If that bed isn't clean, you're risking complete central necrosis of the graft, and nobody wants that. Moving on to local tissue transfer. If you're raising a random flap, what is the absolute safe limit for its length to breadth ratio? You've got to stick to B, a 1.5 to 1 ratio. Remember, a random pattern flap lacks a single named axial blood vessel. It relies entirely on the subdermal and dermal plexuses to stay alive. So you must strictly cap that length to width ratio at 1.5 to 1 or you're going to cause distal tip ischemia. On the other hand, an axial pattern flap is perfused by a direct, named cutaneous artery along its axis, meaning you can safely push for significantly greater length and width dimensions.
Let's head down to the lower extremity. What's our most reliable reconstructive option to cover a weight-bearing hindfoot or heel defect?
The most solid choice is C, the scroll flap. Specifically, the reverse scroll artery flap. It's incredibly reliable because it harnesses the rich vascular network surrounding the scroll nerve, fed by the distal subcutaneous perforators of the peroneal artery. It's just an elegant solution for the distal lower leg and heel. However, and this is a crucial clinical pearl, this flap requires you to harvest the scroll nerve within the fascial core. So, unfortunately, it does leave the lateral border of the foot completely insensate.
Staying right there in the lower leg, when you break out your handheld acoustic Doppler to map the medial aspect for fasciocutaneous flap, which artery's septocutaneous perforators are you hunting for? That would be B, the posterior tibial artery. Knowing your lower leg vascular perforator matrix by heart is absolutely essential. The medial leg compartment gets its supply from the septocutaneous perforators of the posterior tibial artery, whereas the lateral leg relies on perforators from the perineal artery. If you design your flap pedicle directly over a mapped patent Doppler signal, you are drastically improving your flap survival rate.
Now, suppose you need structural bone and you head to the posterior iliac crest for a block harvest. Which specific nerve are you most liable to injure, potentially causing permanent numbness over the skin of the buttock?
You've got to watch out for E, the superior cluneal nerve. These nerves cross right over the posterior aspect of the iliac crest, roughly 7 to 8 centimeters lateral to the posterior superior iliac spine. And a good rule of thumb, always stay medial to that 7-centimeter boundary line. That protects the superior cluneal nerves and saves a patient from permanent buttock paresthesia. Contrast that with an anterior harvest approach, where it's the lateral femoral cutaneous nerve at risk, which can lead to marinalgia paresthetica.
Jumping back up to the hand, let's identify the correct defining characteristic of the benign fibroproliferative condition we know as Dupuytren's contracture.
The right answer is D. It's inherited as an autosomal dominant disease. But what's really fascinating here isn't just the hereditary pattern with its variable penetrance, it's the heavy systemic associations. If a patient presents with those classic palmar nodules and fixed flexion contractures, they are highly likely to be an older male with an associated history of tobacco smoking, diabetes mellitus, or even alcoholic cirrhosis.
Finally, for our last clinical case, you're evaluating a young patient in the outpatient department. They have a growing, well-circumscribed, 8-centimeter deep submuscular mass arising right from the vastus lateralis. The bone isn't involved, and a biopsy confirms it's a low-grade tumor. So how are you staging this soft tissue sarcoma? The correct answer is A, stage 1. Because this lesion is categorized histologically as low-grade, meaning it's got abundant stroma and fewer than 5 mitoses per high-power field, it actually stays broadly within stage 1, despite that 8-centimeter size and its deep anatomical location. Even advanced size metrics up to 15 centimeters won't bump a low-grade G1 lesion out of stage 1. Which leaves us with a provocative final thought for this explainer. As microsurgery and complex reconstruction techniques continue to evolve to treat massive lesions like these, how will next-generation robotics redefine what we consider both resectable and safely reconstructable in the decades to come?